I want to begin today differently. Look at the chair you are sitting in right now. Is it firm or soft? Does it have wheels? Could it slide backward if you tried to stand? In a moment, I am going to ask you to try a movement you have performed thousands of times, standing up from a chair. But you will do it in a specific way, with your arms crossed over your chest, without pushing on the armrests, pressing your hands into the seat, or pulling on anything nearby. After 65, this simple movement can provide useful information about your leg strength and muscular endurance. It may also reveal clues about pain, balance, and overall mobility. Clinicians use a standardized version called the 30-second chair stand test. It is included in the CDC's STEADI fall prevention program and is commonly used when assessing mobility and fall risk in older adults. More than 14 million Americans aged 65 and older report falling each year. That is roughly 1 in 4. Falls remain the leading cause of injury in this age group. But this test does not predict whether you will fall, and it does not diagnose a medical condition. It gives you one useful measurement of how your legs perform during a repeated everyday movement. By the end of this video, you will understand your result, what may have influenced it, and which findings deserve a conversation with your clinician. First, we need to make sure the test is appropriate for you to attempt today. Use a straight-back chair with a firm seat and no armrests. It should have no wheels or swivel mechanism. Place it against a wall so it cannot slide backward. A firm dining chair is usually suitable. A soft sofa, rolling office chair, or unstable folding chair is not. The standard assessment uses a seat approximately 17 inches, or 43 centimeters, high. A much higher chair makes standing easier, while a lower chair makes it harder, so results from different chairs should not be compared too rigidly. Do not perform this as an unsupervised self-test if you have fallen recently, frequently lose your balance, require physical assistance to stand, or have been advised to avoid unsupported standing. Do not attempt it today if you currently feel dizzy, faint, unusually breathless, or unwell. If you depend on a cane, walking frame, or another person to rise safely, watch the demonstration instead and ask a clinician or physical therapist to perform the assessment with you. If you normally stand independently and feel steady today, you may proceed cautiously. Ideally, have another adult stand beside you without pulling or lifting you unless you begin to lose balance. Stop immediately if you develop dizziness, chest discomfort, unusual shortness of breath, sudden weakness, severe pain, or the feeling that you may fall. With those limits clear, here's the test. Sit in the middle of the chair with your back straight and both feet flat on the floor. Place each hand on the opposite shoulder so that your wrists are crossed and your arms remain against your chest. Set a timer for 30 seconds or ask someone nearby to time you. When the timer begins, stand all the way upright. Straighten your hips and knees fully. Then sit back down until you are fully seated. That is 1 repetition. Continue standing fully and sitting fully as many times as you can during the 30 seconds. Move at a steady pace, but do not rush or drop heavily into the chair. If you need to use your hands or arms to stand, stop the test. Under the standard CDC protocol, that attempt is recorded as 0. That is not a failure. It is useful information showing that the unsupported version could not be completed. Count each full stand. If the timer ends while you are already more than halfway upright, count that final movement as 1 completed stand. Before you compare it with a number on a chart, let us be clear about what your result actually represents. The CDC uses the 30-second chair stand test to assess leg strength and muscular endurance. Rising from a chair requires the quadriceps, the large muscles at the front of your thighs, to straighten your knees. Your gluteal muscles help extend your hips, while your trunk and postural muscles keep your body controlled as your weight moves forward and upward. Repeating that movement for 30 seconds adds another demand: endurance. Your muscles must generate enough force, not just once, but repeatedly while maintaining control. That matters after 65 because both muscle strength and muscle mass can decline with age, particularly during prolonged inactivity, illness, or hospitalization. The functional effects may appear during everyday movements, such as getting out of a chair, climbing stairs, or recovering your balance after a stumble. You may hear the word sarcopenia used when age-related weakness is discussed. This test cannot diagnose sarcopenia, which requires a broader assessment of strength and muscle quantity or quality. A low count is a functional signal, not proof of that condition. The chart shown on screen lists the CDC's age and sex-specific cutoffs for scores considered below average. It does not show the complete normal range for every person. Find your age group and look at the number listed for you. A score below that cutoff may indicate reduced leg strength and endurance and increased fall risk. It is worth discussing with a clinician, especially if the result reflects a recent decline or if you also experience pain, imbalance, or difficulty during ordinary daily activities. A score that is not below the cutoff is encouraging for this particular assessment, but it does not guarantee that your fall risk is low. This test measures one part of physical function. It does not fully assess your balance, sensation, vision, blood pressure, medications, or every medical condition that may affect mobility. The formal score is simply the number of completed stands, but the way you moved also provides useful information. Did you hesitate before standing? Did you place more weight through one leg? Did your knees or hips hurt? Did you become unsteady? Did you begin dropping heavily into the chair instead of lowering yourself with control? Those observations do not change the official count, but they may help explain it. Being able to rise once without using your hands is the first step. Repeating the movement for 30 seconds reveals how consistently your legs can produce and control that effort. And this leads to the most important part of interpreting your result. A low count does not always mean simply that your legs are weak. Here is the part most people miss. When someone records a low count, or cannot rise without using their hands, the immediate explanation is often weak legs. Reduced leg strength may certainly be involved. But two people can receive the same result for very different reasons. The most useful question is not simply, what was my number? It is this, what actually stopped me? For some people, the main limitation is pain. Pain in the knees, hips, or lower back can change the entire movement. You may shift your weight toward one side, lean farther forward, pause before standing, or reach for support. Pain and weakness often occur together. Avoiding a painful movement can gradually reduce strength, while weakness can place more demand on an already painful joint. That is why it helps to notice not only whether standing was difficult, but where you felt pain and whether one side seemed to do more work. For other people, the main limitation is uncertainty once the body begins moving forward. Standing requires your weight to shift over your feet before you rise. If you feel dizzy, unsteady, or unable to judge your position clearly, you may hesitate even when your legs can produce enough force. Balance can be affected by many things: reduced vision, blood pressure changes, medication effects, inner ear problems, neurological conditions, or reduced sensation in the feet. Your brain normally receives constant information from the feet, ankles, and joints about where your body is positioned. This is called proprioception, your internal sense of body position. When that information becomes less reliable, as may happen with peripheral neuropathy from diabetes or other causes, standing can feel less coordinated and less secure. Another possibility is deconditioning after illness, hospitalization, or a prolonged period of inactivity. Lower body strength and power can decline during periods of bed rest or greatly reduced movement. A chair that felt manageable before an illness may feel surprisingly difficult afterward, even when the original illness has improved. The encouraging point is that deconditioning can often improve when the medical condition is stable and activity is rebuilt gradually through an appropriate plan. Fear of falling can also limit performance. Someone who has fallen before may pause, reach for support, or avoid moving their weight forward enough to stand efficiently. That reaction is understandable. But fear may also lead someone to move less throughout the day. Over time, reduced activity can contribute to further loss of strength, balance, and confidence. Medication timing is another clue worth noticing. Some medicines can contribute to dizziness, low blood pressure, drowsiness, or slower coordination. If standing became noticeably more difficult after a medicine was introduced or its dose changed, tell the prescribing clinician when the change began. Do not stop or adjust the medicine yourself. The timing simply gives your clinician useful information to review. These factors often overlap. Someone may have modest leg weakness, a painful knee, and reduced confidence after a previous fall. No single issue fully explains the result. Together, they may make the movement significantly harder. That is why the count tells us what happened, but not necessarily why. The next question is whether the difficulty has been stable for years or represents a new change that deserves medical evaluation. Difficulty rising from a chair is sometimes gradual. It may develop so slowly that you begin using the armrests without noticing when the change started. But difficulty should not automatically be dismissed as normal aging. What matters most is whether the movement has changed from your usual level and whether other symptoms appear with it. A noticeable decline from your previous ability deserves evaluation. Perhaps you could rise without your hands several months ago, but now you consistently need to push from the chair. Perhaps your count has fallen, ordinary seats feel harder to leave, or climbing stairs has also become more difficult. That does not automatically mean something serious is happening. But a clear change in function gives your clinician useful information and may reveal a problem that can be treated or rehabilitated. Repeated falls or near falls also deserve attention. The same is true if you increasingly need another person, a piece of furniture, or a walking aid to pull yourself upright. The next signal is asymmetry. The chair stand score does not tell us how much work each leg performed, but you may notice that you lean strongly to one side, push harder through one foot, or consistently protect one knee or hip. That may reflect pain, weakness, reduced sensation, or an altered movement pattern. If it is persistent or worsening, mention it specifically rather than simply saying that standing feels difficult. There is an important distinction here. Gradual or long-standing asymmetry should be assessed by your clinician, but sudden weakness or numbness on one side of the body, especially with facial drooping, difficulty speaking, confusion, sudden vision changes, or a sudden loss of balance, may be a sign of stroke. Do not wait for a routine appointment. Seek emergency medical help immediately. Another meaningful finding is being unable to complete a single unassisted stand, particularly when that is new for you. Some people have used their hands to rise for years because of arthritis, disability, or a previous injury. The result still deserves consideration, but it does not carry the same meaning as suddenly losing an ability you had recently. A new loss of function is the signal that should not be ignored. Dizziness or lightheadedness during or immediately after standing also changes the picture. Difficulty generating enough force to stand is one issue. Becoming faint or unstable once upright is another. Together, they may increase the chance of losing balance. Recurrent dizziness when standing should be discussed with your clinician, particularly if you take blood pressure medicines, have recently been unwell, or have experienced a fall. If the dizziness is accompanied by fainting, chest discomfort, severe breathlessness, a new irregular or racing heartbeat, or sudden neurological symptoms, seek emergency medical help rather than repeating the test. Finally, arrange a clinical review if your declining mobility occurs alongside unexplained weight loss, persistent fatigue, new or worsening muscle pain, progressive numbness or tingling, or changes in coordination. These symptoms do not point to one diagnosis. That is precisely why a generic exercise program should not be the only response. Exercise and rehabilitation may still form part of the solution, but when function has clearly changed, or when other symptoms accompany it, the first step is understanding what is contributing to that change. Once serious or treatable causes have been considered, the next question becomes much more practical. What can actually improve your ability to rise safely and confidently? What helps depends on what stopped you. The useful plan is not simply do more chair stands. It is to identify the main limitation and train or treat that limitation appropriately. There are 4 broad areas to consider: leg strength, pain, balance, and movement strategy. If you completed the test safely, had no concerning symptoms, and simply found the final repetitions tiring, gradually progressive strengthening may be appropriate. The sit-to-stand movement itself is commonly used as a functional strengthening exercise, but training does not always begin with the exact unsupported version you just tested. Someone who currently needs their hands may begin from a higher chair, use controlled hand support, perform fewer repetitions, or work through a smaller movement range. As strength and confidence improve, the support can be reduced gradually. The goal is not to force yourself out of the lowest chair you can find. The goal is to give your muscles a safe challenge that can increase over time. If pain limited the movement, pain management and strengthening usually need to be considered together. Exercise does not always need to wait until every trace of pain has disappeared, but it may need to be adapted. A higher seat, slower pace, fewer repetitions, or a smaller range of motion may allow the muscles to work without provoking sharp or steadily worsening pain. Appropriately selected exercise can improve both pain and function in many people with knee or hip arthritis. But severe pain, rapidly increasing pain, or a newly swollen joint should be assessed rather than repeatedly tested. If dizziness, marked imbalance, pronounced asymmetry, or a recent decline affected your result, a clinician or physical therapist can help determine what should be addressed first. That does not mean every older adult needs supervised rehabilitation before becoming more active. It means the more complicated the result, the less useful a one-size-fits-all program becomes. Balance training may help some people. Others may need their blood pressure, medications, vision, sensation, or neurological function reviewed. Vestibular rehabilitation is helpful for certain diagnosed inner ear balance disorders, but it is not the automatic solution for everyone who feels unsteady. The environment matters as well. A higher chair is generally easier to rise from because the hips and knees begin from a less deeply bent position. A low sofa, recliner, or toilet may therefore be difficult even when a dining chair is manageable. A physical or occupational therapist may recommend strengthening, movement strategies, or suitable equipment for specific problem areas around the home. Your feet also need a stable surface. Avoid loose slippers or socks on a smooth floor. Make sure the chair cannot slide and remove nearby objects that could catch your feet. The practical message is simple. Do not train only the number. Pay attention to what limited you: fatigue, pain, dizziness, imbalance, fear, or the need to use your hands. That limiting factor is often more useful for choosing the next step than the count by itself. Let me bring this together. You now have a result: the number of full stands you completed in 30 seconds. Compare that number with the CDC's below-average cutoff for your age and sex. Remember, the chart does not divide people into healthy and unhealthy groups. It identifies results that may suggest reduced leg strength and endurance and increased fall risk. When you speak with your clinician, give them more than the number. Tell them your count. Tell them whether you needed your hands. Under the standard CDC protocol, needing your arms means the test is stopped and the result is recorded as 0. Tell them whether you experienced pain, hesitation, imbalance, unusual breathlessness, or dizziness. And tell them whether this performance feels normal for you, or whether standing has become noticeably harder during the past several months. Those details turn a vague concern about aging into a specific clinical question. What limited this movement, and can that limitation be improved? If your score was not below the CDC cutoff, that is an encouraging result on this particular assessment. But it does not rule out every contributor to falls. The test does not fully assess vision, sensation, blood pressure changes, medications, walking stability, or hazards around your home. You may repeat the test later to observe change, but use the same chair height, the same setup, and the same 30-second protocol. Otherwise, the comparison may be misleading. If you are beginning a strengthening or rehabilitation program, ask your clinician or physical therapist when repeating the assessment would be useful. Progress may mean a higher count, but it may also mean less pain, better control, less hand support, or greater confidence during daily movement. Your number is not a grade. It is a starting measurement. This video began with a simple question about a chair, but your result tells us something more useful than whether you passed or failed a test. The chair stand test gives you a snapshot of your leg strength and endurance today. It does not explain the cause of every difficulty, and it cannot predict your future by itself. Age, illness, pain, reduced activity, changes in balance, and several medical conditions can all affect how easily you rise. Some of those factors cannot be removed completely, but strength, balance, movement control, and confidence can often improve when the underlying problem is identified and the plan is matched to the person. Improvement may mean completing more repetitions, but it may also mean standing with less pain, using less hand support, lowering yourself with greater control, or feeling safer during ordinary movements around your home. That is why the most important thing you can do with your count is not compare it with someone else's. Record it. Notice what limited you. And if the result was below the CDC cutoff, represented a recent decline, or came with pain, dizziness, or imbalance, use it to begin a specific conversation with your clinician. A chair is an ordinary object, but the ability to rise from one supports many of the things that preserve independence. Using the bathroom safely, getting out of bed, leaving the house, and recovering your balance when something unexpected happens. Your number is not a verdict. It is a place to begin.